Good evening, everyone. I welcome you again, all in this another episode of 4D, which is detailed discussion and dialogue for Indian diabetics. We have a very interesting topic lined up for today. We'll be talking about a disease which has actually got its correct position recently. We have started calling it a disease. Earlier, we used to just say that it's a lifestyle problem, but now as we are understanding this problem, we tend to understand it's not just lifestyle that is responsible for this problem, which is called obesity or excess weight. It is actually more than that, and that's why we have started talking about management of this particular problem. And as we understand more about this disease, we understand that most of our chronic problem, whether it is blood pressure, whether it is CV disease, whether it is diabetes, whether it is OSA, and to some extent kidney problems also are somehow linked to obesity. For this discussion, we have some great uh, consultants lined up for today's discussion. At the first, I'll welcome Dr. Revachand P. Rajdev, who is a senior consultant cardiologist at BAPS Shastriji Maharaj Hospital, Rajkot. Welcome, sir. Uh, we have also Dr. Ronak Bhalodia, who is a nephrologist from Sterling Hospital, Rajkot. Welcome, Dr. Ronak.
Thank you very much for such a nice introduction.
And we also have an endocrinologist, Dr. Bridge Paley, who is a pediatric and adult endocrinologist working at Granthi Diabetes, Endocrine and Obesity Center, Rajkot. Welcome, Dr. Bridge.
Thank you. Thank you so much, sir. Pranam, sir.
Pranam.
Thank you, sir.
So it's an interesting set of, I believe, people. We have a cardiologist, an endocrinologist, and a nephrologist who will be talking about obesity. Let's start with Dr. Revachan. Dr. Reva, how do you see obesity as a problem in your clinic? How do you see it as a cause of CV disease in your clinic?
It's a major contributor nowadays, because the cardiovascular disease is a lifestyle disease, and obesity burden has increased tremendously. In India now, out of the every 8%, 1% is having the obesity, or is on part of the overweight, or is morbidly obesity, and that increases the diseases burden very much, sir. And if we treat the obesity, address as the initial stage of the cardiovascular disease, and a lot of the complications are the complicated further complications in the patient having the ischemic heart disease or multiple PCIs has been reversed, or that could be treated very effectively, sir. Like in this era, not only we treat the cardiovascular disease, also we treat the cardiometabolic, and cardiometabolic pharmacotherapy is the key cornerstone of our management in today's era. And like in the patients having the LDL targets are not achieved with the oral statins, we will go frequently with the inclisiran and other therapies. And in the same way, GLP agonists we are frequently using in our patients to prevent the further cardiometabolic diseases in our patients having the obesity, or they are on the overweight side but not the morbid obesities.
Absolutely right, sir. Dr. Ronak, we heard from Dr. Reva how it drives to the CV disease, but how is obesity related to renal problems? What are the pathophysiological factors associated with obesity that leads to kidney problems?
Yes. There are 5 to 25% of obese people having kidney issues. Most of the reason behind this is first, there is hyperfiltration due to obesity that lead to hyperfiltration injury because of increased plasma flow in both kidneys. Second is obesity itself is a chronic inflammatory condition. Visceral adipose tissue secretes interleukin 6 and another chemokines, which mediates subclinical chronic inflammatory stage in kidney, which increase the progression of the CKD itself, and it is already an independent risk factor to have a kidney disease. Another is another
Yep.
obesity related kidney disease. There is a organomegaly, nephromegaly is there, and which can also lead to focal segmental glomerulosclerosis like pattern.
Yeah.
Hello.
We are listening, sir. Obesity, like you said, is associated directly with the renal problems, and there are certain glomerulopathies which are directly related to obesity, like focal segmental glomerulosclerosis, and there is an activation of RAS system also, which does lead to renal injury because of obesity. Dr. Bridge, I like to go into basics of obesity. So, what are the pathophysiological factors? So, we did talk about lifestyle problem. We earlier used to think that obesity is just a lifestyle problem. It is a difference between what you are eating and what you are using. But now, as we have more in-depth knowledge of obesity, what are the pathophysiological factors that lead to development of obesity, and how endocrinology is associated with this problem?
So absolutely true, sir. So when we look at obesity, we have to move past the old narrative of calories in versus calories out thing. So as an endocrinologist, we can view adipose tissue as a highly sophisticated and active endocrine organ in itself. It's not just sitting there actually; it's pumping out hormones like leptin, adiponectin, and it has definitely that inflammatory loop. It activates the inflammatory cycle, causing insulin resistance, in turn affects all other organs. So when this entire signaling cascade breaks down, we know that there is a very tightly, highly sophisticated, regulated energy balance working in our body. I just mentioned about the leptin and other hormones, which makes the weight sustenance possible in our body. However, now the outlook has changed. Fortunately, it has changed. So we have to look at obesity as a dysregulated endocrine disorder. The basic hormonal synchrony, which is maintaining the weight, the diet, appetite, and the central connections, which lead up to the prefrontal cortex as a voluntary control, and as well as the hypothalamus, which are associated in regulating the diet and appetite. So it's a completely tight, closed loop. And at any stage, if there is a breakage, definitely we go ahead to have the patient develop obesity. And particularly in today's context, when we speak about sleep apnea, right? We want to discuss a bit about sleep apnea as well. So it is also a part of this metabolic loop, and it also exhibits this classical vicious cycle. While the physical deposition of the fat around the airway, which causes the actual blood blockade. However, there are endocrine fallouts as well. So every time when a patient experiences the intermittent hypoxia during the night, say for example during the apneic spell, the body definitely has a stress response to it, and there is a spike of cortisol level. There is an increase in the sympathetic activation, and this again adds to the insulin resistance and makes glycemia into a dysglycemic state. And definitely managing obesity can in turn result in re-regulation of all these domains of insulin resistance as well as the inflammatory cascade. So we have to look at it as a definite endocrine disorder.
Yeah, you're absolutely spot on, Dr. Bridge. Is actually a problem more than just a lifestyle issue. It's an actual problem which leads to dysregulation of orexogenic hormones and anorexogenic hormones, and it ultimately leads to the problem. So, Dr. Bridge just did talk about OSA. How does OSA act as a link between obesity and cardiovascular disease?
There's a definite proven link between these. They affect the cardiovascular health in many ways. like the retention of the fluid, retention of the salt, and sleep disturbance, with the daytime sleepiness and breakage of the rhythm of the cycle affects the whole cycle of the cardiac cycle. And this causes the retention, as well as like arrhythmias could be exaggerated with this.
Yeah, arrhythmias like atrial fibrillation, and it also leads to
Atrial fibrillation, yes.
pulmonary. Yeah.
Yeah,
So all
obesity
of
also
these.
affects like the left ventricular hypertrophy, cardiac muscle stiffness, and deposition of the fat tissue in the myocardium causes the atrial fibrillation, other arrhythmias, and sudden cardiac death. In today's era, we not only treat the cardiac
How often
diseases
do
in
you
the
see-
whole patient, we will do the cardiometabolic profile as well as cardiometabolic genetic analysis, and also treating with the cardiometabolic pharmacotherapy.
So how often do you see OSA as a cause of resistant hypertension in your patients in your clinic? Oh, how do you deal
Yeah,
with
we are
that?
frequently treating such sort of the patients. And after treating the sleep apnea surgically or with the CPAP, there we are seeing lot of the patient, they have the relief with this and decrease in the sudden cardiac death and other cardiac morbidities.
So, Dr. Ronak, again, the question to you: how does OSA lead to renal problems? What is the link between OSA and renal issues?
Yes, sir. In OSA, there is intermittent hypoxia during sleep. That will lead to oxidative stress in all our body and lead to different organ damage. Second is there is increased sympathetic activity during OSA during that sleep, and that will lead to intermittent hypertension during night type sleep. So the patient with severe OSA, they lack night nocturnal dip in blood pressure. So increased blood pressure that also lead to renal damage and ultimately lead to progression of the CKD.
Yeah, absolutely right, Dr. Ronak, that OSA does lead to poor renal outcomes as well. And it does, like I was talking about hypertension, again, if we are able to manage OSA, it will again have its contribution in improvement in renal outcomes as well. Dr. Bridge, as an endocrinologist, what do you look for if you are looking at an obese patient? What are the metabolic problems that you will try to look in those patients?
So if we go on counting, we would end up getting more than 200 overall complications. Of particular interest, as an endocrinologist, I'm sure you would agree, is we want to look at just what Dr. Reva sir mentioned about the hypertension, uncontrolled hypertension or resistance hypertension. Similarly, there may be a scenario where if the patient is obese plus OSA, that can be a condition of uncontrolled glycemic part as well. The patient may be pre-diabetic, the patient may progress to diabetes. At the same time, the patient previously well controlled may suddenly end up getting sugar fluctuations. So definitely that is one part, because I may not repeat, I already mentioned about the inflammatory cycles, the insulin resistance, and the cortisol imbalance. Just like how cortisol, hypertension, there is a diurnal rhythm. Interestingly, cortisol also has a diurnal rhythm. We want the cortisol to be in a very down state during sleep. However, due to this apneic spell, you expect the cortisol to rise. That's something causing the glycemic dysregulation. So that is one part I would like to say in terms of diabetic dysregulation. Second is I want to look at the fatty liver as well, because now we don't look. It's like a twin pandemic. Obesity is driving another parallel silent pandemic of MASLD, I would say. So as an endocrinologist, right from hypertension to dysglycemia, to of course OSA and fatty liver disease, that is MASLD, I think we need to look it as a spectrum, and just by addressing the root of it, everything originating from obesity, we may be able to offer better treatment in all these associated common complications.
Dr. Bridge, you're right in that. What about the reproductive endocrine problems? Of late, I have been seeing a lot of patients, especially in men with hypogonadism. where
correct.
they are having poor semen parameters, erectile dysfunction. If we check their testosterone, low testosterone, how often do you see this in your clinic?
So both in men as well as in female, I would say, both PCOS and hypogonadism. In fact, there is a specific terminology being coming up. It's called MOSH, male obesity secondary hypogonadism. So if we look at our daily practice, we do not routinely go for testosterone measurement. But if we dive in depth into the history of the patient, we definitely see so many hypogonadal feature in terms of men as well as in females. We are seeing a rise in PCO. It's exponentially rising over last couple of decades, as well as infertility. So absolutely spot on, sir. In terms of reproductive function, both in men and women, we would want to look at the hypogonadal features as well as in PCO. And just like any other condition, any other complication which is arising out of obesity, be it MOSH, be it PCOS, weight loss addresses all those domains. The treatment of MOSH, the treatment of PCO in an obese woman, in an obese male is definitely weight management and lifestyle management.
Absolutely right, Dr. Vijay. I just recently happened to see a patient 3 months back, recently married, and the patient was brought to me by the wife's father. He was an obese guy. They were not able to consummate the marriage, and they were actually, the father wanted me to say that the man is impotent, and they wanted it to be a ground for divorce. Fortunately, just by some counseling, some use of testosterone, and some dietary changes, exercise, we were able to change the thing. So I just happened to get a visit again 2 days.
Saved a marriage. You saved a marriage.
And things are getting better, and everyone is now looking. So that's why I just talked about this patient, and it's really one of the things that we off late we are seeing a lot, especially here, obesity leading to hypogonadism and causing these problems. So coming to systemic problems, Dr. Reva, what type of cardiovascular problems do you see in your obese patients, whether it is CHF, fibrillation, or arrhythmias? What type of arrhythmias do you see in these patients?
Atrial fibrillation is the most common, and number 2 is the ventricular arrhythmias. And in some of the patients, we also see the sudden cardiac death. And above these arrhythmias, we also say the resistant hypertension, repeated AMIs, complications of the metabolic disease as well. And there's derangement of the LDL, which is also resistant to the statin therapy. As I earlier mentioned, we will go in these patients for the inclisiran therapy. And in these type of the patient, even on the first presentation, the patient has not developed the MI other things. They has just ACS or angina or initial symptoms. And in those patients, we are nowadays going to the full workup of the cardiometabolic syndrome or cardiometabolic derangement with the obesity and rise of the LDL or apolipoprotein B and insulin resistance. And even we are suggesting nowadays to the patients of the metabolic genetic analysis and pharmacogenetic analysis, which drugs are going to be effective in those patients.
Absolutely right, Dr. Eva. What we see as is what when they come to me with some sort of dyspnea, and what I am worried more about is failure with preserved ejection fraction. Most of the time, their echos are coming saying ejection fraction is between 50 to 60%, and they have nowadays some sort of diastolic dysfunction. How often do you see in this in your clinic with obesity?
More of the diastolic dysfunction in these patients. And in initial visits, either the patient is not the cardiac patient and coming on the only for the health checkup. In the obese patient, we especially see for the complications of this cardiovascular, which patient can develop in the later on. We will insist for the echocardiography monitoring and the development of the LVH pattern or stiffness of the myocardium and diastolic dysfunction. And our other patients who have already developed the LV systolic dysfunction, we strictly monitor those patients for the worsening of the reduced ejection fraction. But in obese patients, non-symptomatic patients, some of the patients have the preserved ejection fraction heart failure type.
So, Dr. Eva, are you using anti-pro-BNP for these patients routinely in your clinic?
No, not in the routine. We routinely monitor them with the echocardiography. And if there is the worsening of the symptoms, even if the preserved ejection fraction in some of the patients, we will go for those. Gold standard is the echocardiography.
Okay. That's perfect, Dr. Eva. Dr. Ronak, you did talk about FSGS in patients with obesity-related renal disease. What other complications, systemic complications, as a nephrologist, do you look for? What type of other kidney problems do you look for in obese patient?
Yes. Similarly, as per Dr. Rivasar says, many a times obese patients come to our OPD for routine checkup and found to have a patient having proteinuria or renal dysfunction in terms of increased serum creatinine. On further research, we have found either patient may have hypertension and hypertensive nephropathies, or patient accidentally detected diabetic and associated with diabetic nephropathy. Sometimes there is also increased oxalate excretion from urine of that particular patient. So might be there is a high prevalence of renal stone also from a obese patient.
Yeah, I absolutely agree with you, Dr. Ronak, and this is what we see in our clinics also in girls with PCOS. Most of these girls are obese and they also have renal stones. When we look at their scans, many of these scans also show renal stones because of this high do have renal stones. Dr. Bridge, once we start managing these patients with the obesity, what are your targets? What is one thing that tells you that this is the amount of weight reduction I should target in this patient? Is it different in different patients? With MFLD, what you will target, in PCOD, what you will target? How do you decide upon this?
So, sir, we do have data suggesting the same thing. Now, the thing is, baseline, we need to make sure the patient at least achieves 5 to 10% weight loss in general, because we want to, the patient may or may not be diabetic. The patient may have some mechanical complication as well. Say, for example, the patient is having osteoarthritis. Now, 1 kg reduction in the weight can actually, take off 4 kg of weight from the knees. So we need to look at what actually the patient is basically suffering from. So in terms of lifestyle management plus whatever pharmacotherapy we are offering to the patient, the first and foremost target is to offer 5 to 10% of weight loss irrespective of what complication we are dealing with. Then the next thing is, if you want to go for only glycemic parameter and hypertension and dyslipidemia, then around 10 to 15% of the weight loss may be good enough to reverse most of the inflammatory part leading to insulin resistance. However, if you want to go for MASLD, the cutoffs may range in different studies from around 10% to around 15 to 20%. And specifically mentioning about the obstructive sleep apnea, that is the last one to recover. So if you want to address the OSA component, we may want to achieve still a higher weight loss, maybe beyond 20% or up to 25% of weight loss.
Yeah, absolutely right, Dr. Bridge. 5 to 10% is what we target. 5% is how we define any drug to be an effective anti-obesity drug. For MSLD, it is somewhere around 10% that has been recommended. For remission of diabetes, somewhere between 15 to 20% what has been recommended. Dr. Eva, what targets do you want to achieve in your patients with obesity, and he has come to you with say HFpEF, and you advise him to reduce his weight, what are the targets, what are the LDL targets, what are the sugar targets that you try to achieve, or what are the blood pressure targets in this patient that you try to achieve?
It depends upon the patient. Is the younger patient, newly diagnosed, or older patient, and chronically debilitated, or chronically ischemic heart disease patients. If this is a younger patient and newly diagnosed, we will achieve strict targets. Like we will go for the less than 70% of the LDL targets and less than 130 of the systolic pressures. And in the glycemic control, we will strictly go hit the heart, and we will try to achieve the less than 6.5% of the HbA1c. And if this is the patient, older patient, which has the multiple cardiac diseases, severe LV dysfunction, then we will be reluctant to have the strict glycemic control. We will gradually go and achieve less than 7% of the HbA1c, and in that patient's LDL, we will achieve less than 50 millimoles.
Okay.
And pressure targets are the systolic less than 130.
LDL targets of less than 50.
Yeah. As a high-risk patient has the multiple comorbidity, multiple blocks, or multiple PCIs. It's a high-risk patient, so LDL target is less
Dr.
than 50.
Ronak, as a nephrologist, what are your targets? How do you target blood pressure and weight in these patients? Any other targets that you want to achieve? Maybe you are looking at protein excretion or those things also in these patients.
Initially, for weight, we target about 5 to 10% weight in around 3 to 6 months to reduce progression, and blood pressure to have less than 130 by 80 systolic and diastolic blood pressure, and we regularly monitor in protein creatinine ratio which is less than microalbuminuric level. To reduce the progression of CKD. So ideally, one can monitor albumin creatinine ratio, protein creatinine ratio, which should be in less than 300 milligram per day. And in high-risk patients, we weight reduction.
Absolutely right, Dr. Ronak. Dr. Bridge, how do you go about it? How do you start this conversation? How do you advise about lifestyle modification, and what are the drugs that you use?
So we need to first make sure that the patient is in a comfortable way to be able to discuss the obesity, because this has not been done for so many years. Most of us as physicians previously, we used to just tell the patient that just reduce some amount of calories, get down on your roads and gyms, hit the gyms, and then go ahead by changing your lifestyle. So we need to first sit with the patient. The art of obesity treatment starts off by giving time to the patient. We need to counsel the patient. We need to spend into depth with the patient in counseling, that you should first of all remove that stigma, remove that guilt that obesity is your fault. That is the first thing. Second is, you should start understanding the fact that obesity is now a proper disease, like how we treat diabetes, how we treat any heart condition, any other disease. We need to look at it as a metabolic disorder. Second thing. Next is, we need to explain about the complications which can arise out of obesity, like how while counseling a diabetic patient, we explain to the patient that if you don't get the proper treatment, you may end up getting nephropathy, retinopathy, and so on. The same way, an obese patient may not actually be diabetic, but we need to explain to the patient that today's obesity is a ground for future diabetes, future dyslipidemia, future hypertension, future MSLE, future OSA. So if you start addressing the obesity right now, even if the patient has developed complication, we need to get into the brains of the patient in such a way that the patient is actually able to reflect what our views are. Then the patient will be able to grasp the concern associated or the future concern associated with obesity, and then that's when we can step in the management aspect. What I personally do in my practice is I leave all the options open to the patient. I'm not pushing it any pharmacotherapy to the patient. I explain about the various options starting from lifestyle. I explain about the limitations of lifestyle modification. It can give maximum up to 3 to 5%, and 80% of those weight loss achieved by lifestyle modification relapses within next 5 years. And then I go on about discussing various pharmacotherapy in terms of GLP-1s. If the patient is diabetic, I give the option of oral GLP-1 as well. If the patient is not diabetic, I only explain about the once weekly GLP-1s as well as the twin creatine, as well as the bariatric surgery. So then there are cost concerns. We need to address the cost concerns as well. And then we need to take an informed decision as a team with the patient. We cannot just enforce our views to the patient that yes, this is the best medicine for you, this is the right approach for you. Start taking GLP-1s, you'll be fine. This is something the best thing you can get. No, I don't think I take it that way. I discuss as a part of the family of the patient, as a part of the care team of the patient, and then we together we take an informed decision. If the patient wants to go for a lifestyle for let's say 3 months, we can allow the patient to try about the optimum lifestyle modification. And at a particular stage, when the patient is 100% sure the patient cannot achieve beyond a certain amount of weight loss, that's when we can actually pitch in terms of offering pharmacotherapy.
Yeah, and Dr. Bridge, how do you see your practice is going to change after this? The drug is the cost barrier is going to go away, especially with the GLP-1 RA now with Indian companies pitching in with this new molecule. How do you see the practice is going to change?
Sir, I look at this issue in two domains. Of course, before the patent is going off, we all have been using it enough for last 1 year or so. Both the GLP-1 as well as the GLP dual taking. Now the issue with the off patency, we need to address in two domains. Firstly, so far none of them I have gone through the actual data from the off-label pharma. So I'm skeptical about actually applying. Second is they still do not have the approval in terms of obesity. Most of them, the approval what as of now the information what I have got is the approval has been given only in terms of GLP-1 to be used in diabetic plus obese patients. So in those non-diabetic, the patient who do not have diabetes, I may still want to wait for actual data and approval. That is one thing. Second is, of course, the cost barrier has been a major restraint in terms of offering it to our patients. Maybe if we counsel 10 patients, hardly 2-3 patients are actually getting ready to use it as of now. So maybe getting away with that cost barrier, coming it in an affordability range, we may definitely want to offer it to more and more number of patients. However, my way of practice, what I have learned so far is never be the first one to do anything. Wait for a significant few week time, see how it is reflected in your circle, in your community, because there are many other concerns as well. We may not be at the right platform to discuss those the manufacturing related concerns. But yeah, if all goes well, definitely it's going to be our first choice drug in so many patients. In fact, even before it has gone off patent, I have prescribed it to so many patients, BMI of 23, 24. But just to offer the cardiorenal benefits, to make sure our patient achieves the best possible combination of therapy to address the cardio outcome, renal outcome, as well as the glycemic outcome. But after the off-patent thing, my view is to give some time to wait, see how it is reflected, how it goes along the next few weeks or few months, and then see which is the best choice to take on our pen.
Yeah. So yeah, absolutely right, Dr. B. This is what I also think that we'll have to wait how this plays, how the molecules are going to be, and but I'm at the same time also excited about our patients that being the pharmacy of the world, we at least have this luxury to at least advise our patients one of the best molecules for the management of diabetes and metabolic problems. So at least we have that in our armamentarium now. Dr. Reva, as a cardiologist, what are the medications you use for managing obesity in your patients? What are the drugs that you use as a cardiologist?
We will divide the obesity management part in three sections: the dietary advices and the workout or exercise, the aerobic exercises for the 30 to 45 minutes per day, or around about to 300 minutes in a week. And in the medications, we will use the GLP agonist. And otherwise, we will manage the hyperglycemia, will strict control of the blood sugars and target achievement of the HbA1c. And in the counseling sections, we will divide these our patients in the newly diagnosed overweight patients and otherwise other patients who are on the side of the obese, and obese patients with the already cardiac diseases are worsening, newly diagnosed cardiac diseases are worsening of the previous cardiac diseases like MIR, heart failure. And we also do a counseling session for the relatives or family members of the cardiac patients, and their risk factor as well.
And how often are you using these GLP-1 RAs in your practice, and what do you as a cardiologist feel about these newer drugs that are going to be available with a patent going off soon, and how this price barrier is going to affect your practice as a cardiologist?
In almost about 10% of our population with an OPD or whatever the patients we are seeing are on the side of the higher weight or obese patients, and in those patients, 30 to 40% patient have the easy acceptance in this era, and definitely after the patent is off and the prices is going to lower side, the acceptance will be improved.
Yeah. Same question to you, Dr. Ronak. As a nephrologist, how do you manage obesity in your clinic? What are the advice that you give to your patients?
Yes, sir. First of all, I do a risk factor certification, and in mild risk factor, patient with mild risk factor, we advise dietary and lifestyle modification for at least 3 months. If patient is adherent to that, and even after that further weight reduction is required, then we are advising three things. First, correction of obesity associated risk factors like hypertension, blood pressure control, blood sugar control in HbA1c less than 7, blood pressure target around 130 by 80 millimeter per mercury. And third thing is pharmacotherapy. We currently SGLT2 inhibitor and GLP-1 analog is widely acceptable. It also FDA approved to reduce progression of renal disease. So but currently there is a cost barrier, so as we talk about, when this barrier is cut down, definitely so much of patient get benefited by that.
Yeah, absolutely right. Dr. Ronak, one thing that I like to discuss over here is many of our patients are skeptical about their protein intake, especially if they are having proteinuria or if they are having a mild increase in their creatinine levels. So, what is the amount of protein that you advise in these patients? Do you restrict them on proteins? Do you continue them on proteins? What is your take on this?
Yeah, in Indian scenario, in Gujarat particularly, most of the patient are having a vegetarian diet only. So in vegetarian diet, I cannot apply aggressive protein restriction around, because they are only taking around 0.8 to 1 gram per kg in a day. So our target is around 0.8 gram per kg. If patient is exclusively non-vegetarian, then we have to advise him stop to take non-veg and use protein ingredient from vegetarian diet only.
Okay. So is there any amount of protein that you advise or do you advise, like for vegetarian to achieve that amount of protein intake, do you advise them on any protein supplements like whey protein, or do you restrict them on these?
No, we restrict in 60 kg patient around 35 to 50 kg protein per gram protein is per day is enough.
And for vegetarian, it becomes really difficult to achieve that amount of
Yeah.
protein
So that's
intake.
why I told you Gujarat, but most of the majority of
Mm.
population takes only vegetarian diet.
Mm.
So we cannot, I cannot restrict too much for protein
Mm.
intake in that patient only.
Okay. Uh, Dr. Bridge, uh, uh, what do you see as future? So we are already we are going to look into these molecules where we are seeing that practically with twin cretins we are able to achieve weight reduction which is very near to what is achieved by many of the bariatric surgeries. Not up to maybe the Rho and Y bypass, which leads to 25-30%, but the newer molecules, with the availability of newer molecules, which have now reached to that stage, also up to 30% weight reduction has been shown with some of the newer molecules. So, where do you see these molecules? An exciting time to be an endocrinologist or a barophysician, I'll say.
Right, absolutely, sir. It's very, really, really exciting times. I think this molecule has stood the test of time, at least for 1 decade, I would say. And we have had experience using liraglutide. I think it's something less talked about in many of the forums. Just because we are into once weekly domain, we cannot take out the help we have had using the previously approved or previously, widely used molecule that is liraglutide. The interesting thing, just before I come to what you have asked, like to mention that I have gone through few studies, Indian studies specifically. The Indian phenotype or the Indian obese patients, they have responded it way better compared to the Caucasian counterparts using liraglutide. So the Caucasian data used to say around 8 to 10% of weight loss maximum using liraglutide, but there have been meta-analysis saying that people have been able to achieve 12 to 15% of weight loss using lira during those times. So that is one thing I would like to say in promising terms, that because there is a definite difference in how the Indian obesity behaves in terms of visceral adiposity, we need to look at it is even more important compared to the Western counterparts. Because if you take two individuals, one say from the West and one from India, both having BMI of 25, then the Indian obese patient is at a higher risk to have the metabolic complications compared to the Caucasian counterparts. So that is one thing I'm excited about, that we may be able to respond way better compared to the Caucasians. So that is one thing. Second is just as you mentioned, there are molecules in the pipeline. What you mentioned is triple agonist liraglutide, which is now one of the upcoming things which we may be able to get in near future, which may score weight loss beyond 30%. So that is one thing. Only things I'm having my fingers crossed is anything exciting has its own set of disturbances in many ways. In terms of, we do have some molecules in the past which were very promising during those days, but due to some side effects, some random thing, they have been banned and blocked and taken over. So I'm just keeping my fingers crossed we do not encounter any such mishap, because with the easy availability, there will be absolutely or equal increased misuse of the molecule. People, we do have news online from West countries, specifically US, when we do come across examples of the same molecule being misused in various domains. So with the easy availability comes easy access. With that comes easy misuse. So I think we need to, strike a balance between the both things. At this, along with the exciting, we need to restrict ourselves to following science, to using it in a proper indicated fashion, not to use it just like any other off-label over-the-counter medicine, and so that we can preserve the efficacy of the molecule, or we can actually make the best use of it. Because once that negative publicity will start growing, the entire discussion will divert from the actual or genuine use of the molecule to the negative domains, and we know about how things can go from our previous experiences. So I'm keeping my fingers crossed, no mishap happens. So that's why I want to keep it very calm, easy. We want to take time, and we do not want to make it something which may end up in a totally different direction.
Yeah, you summed it very beautifully, Dr. Bij. So I believe we have already reached our stipulated time. It's 10, and it was really interesting discussion. In last 45-50 minutes that we have passed, they went by, and it was really a scintillating discussion. So before we go, Dr. Ronak, your last comments before we go.
Yes. We have to see about obesity as a individual risk factor for CKD progression. So my take-home message is to screen all obese patients when they come to everyone's clinic and see metabolic and kidney care as integrated for treatment.
Thank you, Dr. Ronak. Dr. Bridge, take-home message from your side.
So, very simple and straightforward take-home message. Yes, obesity is a disease. There are cardio-renal metabolic concerns associated with obesity, including diabetes, and it is treatable using very efficacious pharmacotherapy in today's era.
Yeah, absolutely spot on, Dr. Bij. Dr. Reva, last take-home messages from your side as a cardiologist. What will be your take-home message?
My take-home message is that recognize the obesity as a primary cardiovascular disease target, not as the secondary. It's the mother of all the diseases, mother of the cardiovascular diseases.
Absolutely right. So all our three experts are absolutely spot on of saying that obesity is the root cause of all our metabolic problems, is one of the important causes of CV disease, and it is one of the primary causes. And like Dr. Onyx said, that in your patients with kidney problems, obesity can be one of the major reasons which is behind this. So I'll thank all our three experts, Dr. Auran, Dr. Bridge, and Dr. Eva, for joining us today for this excellent discussion. It was a pleasure to be in your company, and it was a great discussion. Thank you. And with this, I'll pass on the stage back to the organizers. Thank you and good night.
One last line from my side. Those patients who are coming for the health checkup, and if we find that someone is on the higher side of the weight, not on only the obese patients, we always suggest the full workup of this, and we will always suggest and recommend to them to meet our dietitian, to meet our the physiotherapist for the exercise plan and diet plan.
That's good. That's a very good message. Thank you, sir. Thank you and good night.
Thank you, sir. Good night.
Thank you.